Good morning. I'm Denny Yamamoto. I'm one of the gastroenterologists here in Reno, and I've been asked to talk about a couple of different GI topics. I picked fatty liver disease. So if we could have my first slide. So this slide set that I have is through a Northwestern repository, if you will, of slides. And Dr. Ranella has been so kind to allow us to use these slides. So really the topic of fatty liver disease or non-alcoholic fatty liver disease and NASH, they're not one and the same. And we're going to kind of talk about that, how that gets all a little confused. But it really is a problem and this title is quite appropriate. It's not so new. I mean, it's been around for a while. We're now trying to deal with it and get our arms around it. I think we already knew that this was there. I think the idea how we evaluate the patient and get into treatment is the major question mark. So, having said that, next slide. So this is the striking and scary thing that we're looking at. It's the train that's already left the station, and we're in the end of the tunnel. It's coming right down at us. And that's the idea that non-alcoholic hepatosteatosis, the inflammatory component of non-alcoholic fatty liver disease, leading to cirrhosis. So right now, between the ages of 35 and 49, the most common need for liver transplantation, the etiology, is this whole NASH issue. And it really is tied into the whole obesity epidemic that we're dealing with. Hep C is going to go away, hopefully in my career. But I've been, not say burdened, but I've been challenged with Hep C since I was in medical school. I wrote my paper in medical school on non-A and non-B hepatitis C, and we've come a long way. And I think with the new advent of therapy, the number of C patients requiring liver transplantation in the future is going to fall like a stone. And what I mean by that is, as we now know, after having direct-acting antiviral therapy, that the risk of transplantation really falls, that the inflammatory response in the liver, the injury to the liver really falls off if you can get rid of the virus. And a lot of these patients will not require transplantation. Their liver disease will smolder along and not require any intervention. However, the other thing that we're going to talk about today is this whole NASH component and the impact that it's going to put on the population. Realize that there's more people obese and having non-alcoholic hepatosteatosis than there are patients with Hep C. So kind of put that in perspective, and just the sheer numbers of patients we're looking at dealing with. And again, it really is tied into this whole obesity issue. Next slide.
So you got that clicker.
Right. So up or down?
To the right. To the right.
So we're going to talk about with a patient, and this is this is a very, not necessarily common, but it's this scenario that I see where patients are being sent to me by a primary care physician because they have abnormal liver tests. And today's talk is to kind of streamline when to send, what to work up, and when to send to a specialist. So they're sent to me because they have this combination of ALT and AST abnormality. And the liver tests have been normal over the few years prior to this. Has a ferritin of 500, and really the guy's not on any medication. Now, everybody targets the ferritin of 500 as saying, oh, this has got to be iron overload. Realize that ferritin is a very sensitive acute phase reactant. So any kind of inflammatory thing is going to drive that up. So that alone is not enough to make the diagnosis of iron overload. There's more to that answer, I guess is what I'm saying. He really fits someone with non-alcoholic hepatosteatosis with hyperlipidemia, type 2 diabetes, and if you look over his physical exam, he's got a BMI of 32. So he really has, fits the whole thing of metabolic syndrome here. So with that, these are other additional factors. His mother has diabetes and hypothyroidism, and his dad's alcohol-related cirrhosis. A little sidebar to this, we all have patients who drink like crazy, have more alcohol consumption than you wonder how they even stand up, but they never get liver disease. Yet there's other people who don't have that same alcohol exposure who get full-blown cirrhosis. So there's some kind of susceptibility or some kind of innate biology of the patient that makes them more susceptible to alcohol, far beyond alcohol dehydrogenase deficiency. I think we're getting beyond that. We know that there's more components to it. And maybe the Human Genome Project is going to let us sort that out. But clearly not everybody has the same sensitivity to alcohol. So you go over and look at his exam. There's really not much other than the central obesity. And you know, he has a little bit of difference in his autoimmune characteristics. He also has a complication or an associated disease of his skin when you look over his physical exam. So he has another autoimmune component to his disease. So one of the things here is to, when you see some of the abnormal liver tests, is to exclude other etiologies before jumping on the diagnosis of NASH. And so you may exclude the alcohol component, interview the patient, interview his family. Does he have what I call open access to a local bar, that kind of thing. And then one thing I frequently ask, I think we all should do, have you ever had problems with the law having been pulled over for DUI? Autoimmune liver disease. There's a component here with autoimmune issues, his mother having hypothyroidism. One thing to remember, as young as this person is Wilson's disease, and just to remind everybody, Wilson's disease is a copper overload disease. Can be difficult to make, the diagnosis to make, but to be clearly thought of. And copper studies, ceruloplasmin, and liver biopsy with total iron and 24-hour urine copper is frequently helpful to exclude this diagnosis. And it really happens more in the young. And the reason to make sure that this is not the diagnosis that would not found, not treated, patients die. They develop progressive liver disease, cirrhosis, and die early. A little side note really brings it down to the nitty-gritty. When I was a fellow, there was a 18-year-old girl playing in the basketball tournament in Wisconsin who collapsed on the floor, vomiting blood. And she came in. We were concerned, obviously concerned. There was some peptic problem, etc. Looking at her, we thought, she had a bit of a yellowness to her skin, and there was concern that something else was going on. And we had just started intervention with the scope to deal with bleeding varices, and we did an urgent endoscopy and found that this young 18-year-old, very athletic girl had varices. We treated them, worked her up. She ended up having Wilson's disease. She was the oldest of 10 children. 7 of her siblings ended up having it. We screened them. None of them, obviously, ended up having the same problem she did. She ended up having a liver transplant within 6 months of that diagnosis, and she decided to have a career as a nurse and became a huge liver transplant advocate and ended up being the nurse in charge of the liver transplant. Quite the story. The other things to think about is viral hepatitis. We now have very good serological markers for both B and C. Remember, Hep A does not cause chronicity, but Hep B and C, luckily with immunizations, what I call native-born Hep B is falling off quite dramatically, which is nice. I haven't seen a acute B in quite a few years. And the C issue is falling off as we've gotten better with blood screening and treatment. Hemochromatosis, iron overload. Just to remind everybody, since I've been graduating from medical school, there are now 5 different pathways to iron overload, over and above the genetic hemochromatosis that we were all taught. So there's more to iron overload. So just doing the genetic testing, looking for iron studies is really falls short of the mark. You probably pick up maybe half of the patients that have it through the current genetic markers that we have. But there are other pathways that have no marker at this point. So we really just need to concentrate on the serum iron studies. And a saturation over 55% really deserves workup as being iron overload. Not as just total serum iron at 55% saturation. Your ears and your radar really should get picked up. So we talked about the other causes that can cause hepatosteatosis: alcohol consumption, malnutrition. And remember, malnutrition doesn't mean they have to be skinny. Malnutrition can mean that they just eat poorly. You can have a very obese patient who's terribly malnourished. Medications, there aren't many on this list, and there are a few patients out there, but not as many patients on total parenteral nutrition chronically that we've had in the past. I think that's due to better surgical intervention and preservation of gut, and some of the dietary things we do now with patient with short gut. There's also, on the sidebar, there are 2 centers in the country that actually do gut transplantation. Quite the endeavor, and it turns out that your gut is the biggest immunogenic organ that we have. A lot of people forget that. It makes immunosuppressive therapy for these patients very difficult. So examples of other liver disease that we could get muddled in with the other causes of fatty infiltration, inflammation, is Hep C. Acute hepatitis D, without B, you can't get D. So we don't see a lot of D in Nevada anyway, especially in northern Nevada. We'll talk about Wilson's disease, iron overload, and some of the lipid problems, including, I haven't seen lipase deficiency yet. Maybe I just haven't looked hard enough for that patient. So ultrasound, something that's readily available all over the state. And these are some of the things that make you think about it, make you think that the patient has fatty liver disease. Not a good test just to have it alone. So how reliable is the ultrasound for fatty liver disease? You can read the slide here. Not very specific, just looking at the liver. And I'll make a little comment about what I mean by that in a few slides. So you really can't distinguish that from any other problem. You still need all the serological help you can get. When the ultrasonographer says, well, this may be early cirrhosis, take that with a grain of salt. You really need some other parts of that study to help you make that decision. So here's the important part. We know that patients with fatty liver disease not found, not treated, really don't do so well. If you look here at the statistical risk of premature death when followed by cohorts, and so it really is a problem that one needs to pay attention to and follow. And this is probably one that's really fallen off the radar, which we're trying to get back on the radar. Okay, so we know that there are numerous patients with fatty liver disease who then subsequently have NASH. Let me go back to this other part of this slide. Is that, remember, fatty liver disease is a part of the metabolic syndrome, and so some of this mortality increase is probably related to, as you can see, cardiovascular disease. And remember that obesity is another increased risk factor for malignancy. So having said that, with fatty liver disease, you have so-called non-alcoholic hepatosteatosis, and even this is even worse. You have the issue with falling with increased mortality by having NASH. So intervention, especially out here, is probably very important. Make diagnosis so one can stay on this line. So identify risk factors for non-alcoholic hepatosteatosis. So it's a bidirectional. In other words, increasing development of diabetes. You can read the slide. I'm not going to read the slide for you, but remember that because you have diabetes, you need to really think about having NASH. You have NASH, you got to think about having diabetes. So to really go through all the various lab tests, lifestyle issues that will put patients at risk. All right, so when you look at, say, have patients short of doing a liver biopsy, these are some of the ways, some of these to think about it. Postmenopausal women really have an accelerated risk of this. Advanced age, and this may be just the idea, when did you get on the bus? And how long have you had this? Remember, it's a very slow, smoldering scarring process. And remember, your liver has only one way to respond to any kind of injury, be it viral injury, be it metabolic injury, and that is to scar and develop cirrhosis. Race of higher incidence with Hispanics and us Asian people. When we looked at that, it may be more dietary issues because now, unfortunately, the developed parts of Asia, fatty liver disease is on the rise, and I think we think a lot of it's because of introduction of the Western diet. Decreased prevalence in blacks. There's some protective, maybe genetic pooling of blacks. We're not sure why, but their risk is lower, interestingly, but their obesity risk is higher. Hypertension, central obesity, we talked about that. Especially patients who have hypertriglyceridemia and have low HDLs. They really run a greater risk of having NASH. And then with that, obviously comes back more insulin resistance and diabetes. Again, you can read this slide on the far right there, that 66% of patients older than 50 will have some evidence of fibrosis and injury with the hypertension, central obesity, and hyperlipidemia. So the old adage of AST being higher than ALT and low platelets probably has more to do with alcohol consumption causing this change in the liver profile, and with that, the low platelets. And we'll talk a little about low platelets and why that really looks at cirrhosis. And persistently elevated ALTs. And really, this is a marker here that we really need to look at as when we start treating people, driving that down and getting that down really is an improvement in the overall disease. Without that, there's clear progression. So we need to figure out the scarring and how much of this really means, what it means, and all the different testing that we now have to make this differential diagnosis. So look at the central part of the screen. This is non-alcoholic fatty liver disease. And it breaks down into, if you go to the left, isolated steatosis, no inflammation, probably does not lead, if you treat their underlying obesity and some of the other metabolic issues, we talked about bidirectional, does not lead to steatosis and inflammation. Left untreated, you can move further and further to the right. And with that, moving further, with that will be the whole non-alcoholic hepatosteatosis. If we go down, fibrosis into cirrhosis. So clearly 25 to 30% of people that we initially see with non-alcoholic fatty liver disease really have NASH. And they really need to have some kind of intervention look for treatment. And again, with treatment, you can stay in that 40, if you go to the far right, stable 40% area. Left untreated, you can see progression to cirrhosis. And with treatment, actually, there's a lot of patients who actually get better. So there is really quite a bit of good data at this point to do something about it. What that something is still unclear, really unclear. So people say, well, I've had normal ALTs for years, and now my first ALT is abnormal, and now you're telling me I have cirrhosis. What happened? Did my doc miss it? What is it? So there's good data now just to show actually percent elevated ALT may not, it's associated with progression of disease, but you can have people with normal ALTs who have the metabolic syndrome, who fit the pattern for non-alcoholic fatty liver disease, who have normal ALTs and still have underlying liver problems, liver inflammation. So there's no designated cutoff. Everybody says, well, when do I need to pay attention to these patients? And there really is no agreed upon cutoff for ALT, unfortunately. We're going to get better with that, especially some of the current cheap screening tests, i.e. a chemistry panel, but more to come. And there's a big push to get the ALT normal level dropped. A little bit of controversy there, but dropped. Some of the normality that we have, the normals really are normals that they're designed in the 60s and 70s, and well before a lot of you were born. And now with the current population, maybe we need to do another restudy that and change our ALT cutoff. And probably it's going to be lower, to be determined. So the tools, that we have, obviously we have blood work, and you can read this through. There's no good test to help us determine whether the patient has moved from that 20 or 30% of non-inflamed liver to inflamed liver, leading to cirrhosis. So the gold standard is on the far right down. Liver biopsy is still there, but I think there's a lot of things that we need to do before we do that, because it is an invasive study. 1 in 10 patients will have an adverse outcome of, 1 in 100 patients will have an adverse outcome of a liver biopsy, i.e. a significant bleed. And that was put in front of my face again after doing this for 30 years when I had a lady who ended up in the ICU needing a 7-unit blood transfusion after 2 passes with the liver biopsy. And she had inflammation but no cirrhosis. And that was a bit scary, obviously, but it really brings to the point you still have to advise your patients there's a risk. So you can look at the slide and tools that we have. There's, again, no clear one MR, CT that pulls everything together. They all contribute to the answer. However, if you look at dollars and cents, an ultrasound of the liver and abdomen is probably one of the most cost-efficient things you can do. And I say that, but I say that with the caveat that you actually have to ask your ultrasonographer to pay attention to a few things that you want to know. So I have, and it's been well talked about by a lot of hepatologists, that there's a rule of 12 off the ultrasound that really helps you decide, yes, this patient needs to see a specialist. They have probably portal hypertension, they have cirrhosis. And the rule of 12, if you remember anything out of this lecture, if you remember rule of 12, it'll go a long way. A 12-centimeter spleen and a 12-millimeter portal vein is portal hypertension, cirrhosis, and to proven otherwise. Rule of 12. If you remember that and you ask your ultrasonographer, I want an abdominal ultrasound. If you tell them just liver ultrasound, they're just going to give the readings of the liver. You want the spleen included. So when you ask for an ultrasound, and I don't think it costs much more, and you're really targeting is on the request, say, I want to know what the spleen size is, and I want to know what the portal vein size is. For the dollar spent, the ultrasound is a very good test, reproducible. And I use the term reproducible because this is not a musket. This is not a one-shot wonder here. It's something you're going to follow through. So something that can be referred back to year, 2, 3, 10 years later and get an idea of progression of the disease or stabilization of the disease. Again, a very good test. If you look at the sensitivity and specificity for the dollar spent, it's pretty good. So remember the ultrasound. Everybody who you think has liver disease, no matter what etiology, should at least have an abdominal ultrasound with the whole rule of 12 being targeted. Again, if you don't remember anything out of this lecture, Remember, rule of 12, it will really go a very, very long way. So limitations of non-invasive testing. Remember I told you the gold standard is liver biopsy. I'm not saying that everybody should have that, but we don't have any, right now, we don't have any one tool that short of liver biopsy gives us that answer that we want. Now I say now, because I think with some of the new serological testing that's coming out, as well as the new elastographies, there's a new sound wave technology that comes looking for liver stiffness. I think the combination or constellation of those symptoms, laboratory tests, and the non-invasive high-frequency ultrasound, I think there's going to be a formula that you can use to help us decide, okay, who and how do we follow these patients and who needs the liver biopsy. So this is some things that have been put forward, and I'm going to talk about transelastography, and that's the fiber scan that we now have here in Northern Nevada. I believe Renown now runs that. Don't have your local radiologist run out and buy this machine. They will, A, not know what it's about, B, they won't know how to use it. There's a fairly significant learning curve how to use this. The company is very, very supportive that's promoting this. The other two there are quite expensive and still very much the experimental phase. There are probably close to 1 million patients who have had elastography across the world. So there's been some good standardization, good information, and good numbers, readings that we can now hang our hat on. And it really is kind of a neat study. I had one of these things done to myself. There was a big meeting we have every May. It was in Washington, D.C. not too many years ago, and I put myself on the table and had an elastography done on my liver. It is painless but gooey. It's like any other ultrasound. It puts right up against your skin, and you can't feel it at all. Maybe a little vibration, but that's about it. And it's amazing the imaging that you can see. My wife was standing next to me, and she says, "Is there anything there?" And the guy said, "Yeah, it's a normal liver." And she looked at me and she goes, "That's the only thing that you have normal in your body." Spoken like a wife for 42 years, right? All right, so how reliable is non-invasive? We just kind of talked a little bit about that. And fibrosis staging and NASH, we want to know who has 1, who has 4, and how do we get there, how do we prevent this from happening. And again, you see this is all pathology. This is how the pathologists grade and give us a sense of what's in the liver biopsy. So the non-invasive diagnostic tools that we now have, and everybody immediately runs over to the right looking at elastography since it's kind of new. Anything new is always better, right? A new sports car is already better than an old one.
That's true, by the way.
But so if you concentrate on the testing in the middle there, the clinical laboratory test, I think that gives us a lot of help, at least to know who needs to move over to the right. And again, AST platelet ratio index, there's some numbers going to come out. If this ratio meets a certain threshold and you keep moving over, you start doing more complex studies with laboratory testing, FibroSure, or some of the serological markers you can see in the middle there. But one of the take-home messages here is platelet count. I always push on my medical students, what is the most sensitive test for cirrhosis? The cheapest and sensitive test. And they're running over, all the students are running over, well, we need elastography, etc. No, it's in the CBC. It's your platelet count. Remember, a large spleen sucks up platelets. So you have some of the portal hypertension. You have a splenic enlargement. Their platelet count's going to drop. And you can see this if you follow patients with liver disease over the years. 300, 200, 150, red lights, the yellow light stuff going on. 110, 100, red light stuff coming up. So platelet count is a very sensitive test that you can follow when patients develop portal hypertension due to the splenic enlargement and sequestration of platelets with a large spleen. So really push on my students to make sure to pay attention to that. We take care of a lot of sick patients with liver disease, and one of the first things that crashes when they crash is their platelet count. They do not have, their bone marrow does not have the capacity to maintain the demand due to large spleen that keeps sucking them up. That really sequesters the platelets. All right, so again, they're trying to come up with this scoring mechanism. It's not quite ready for prime time, so I'm not going to spend too much time on this, but in the tools that you'll be receiving within the next couple of years, you're going to have further talks. They'll say, okay, we have this as my non-alcoholic fatty liver disease score. When do I move over to thinking my platelet has NASH? So you can see there, we're not, again, I'm not going to spend too much time on this, but this is the proposed cutoffs when you add these different tests up. And this is some of the cutoffs that you're using. So non-invasive testing with the liver, with blood work, you can see here the negative predictive value. Because what you want to do is exclude advanced disease. And that's the highlight, right? We want to know who we need to worry about, who is in that 30 to 40% of patients that have non-alcoholic fatty liver disease who will now have inflammatory fatty liver disease or NASH. And that is what we're trying to figure out, short of a biopsy. Who needs the biopsy? So we talked about the new imaging tests that's happening. You can see there's more of these. There's fancier MR scans with more color issues, looking at blood flow. 40 years ago, when I was a resident, MR scan was just being thought about. 30 years ago, I was told MR scanning will never be ever utilized for the abdomen. There's too much motion. It's impossible. That has obviously turned out not to be the case. There's a lot of smart engineers there have allowed us now to do things in the gut, and more to come with blood flow and how this imaging is done. Diagnostic performance, again, FibroScan, really pretty good test, and part of the test is predictability and reproducibility. And you can look at the numbers on the far right. We are looking primarily in the middle with the FibroScan. I think the community looked and see what was the most cost-effective test, most reproducible, and the FibroScan has the best, I think, results. Also, remember, you got to know what you buy and who you buy from, and this company has been very, very supportive, not only after they sell you the product, but very supportive in making sure you have all the support to make this work. Nothing like buying a brand new car and then your dealership goes out of business. So I think that's was part of the equation as to why we decided, why the community went with FibroScanning, and most academic centers are going in this direction. Okay. So again, another part of the elastography, getting better with the different vibratory technology that we have, and just really trying to make this more reproducible. And I think with the popularity and the science engineering science that's coming out with elastography, there's going to be more and different devices that are coming out. We're not quite there in prime time. All right, so we're looking at the things that make things more difficult. We're trying to get out of there. How much inflammation? As inflammation changes, does my reading change? How many different fat layers I need to get to have a good image? Any ultrasonographer will tell you the more adiposity between my probe and my image is my organ, the more difficult getting good imaging. And you can see these are some other things that make things more problematic. Congestion, people with congestive heart failure, how does that change my image? Again, we talked about magnetic resonance elastography. again, this is about stiffness, and a lot of it's about blood flow. It reflects how difficult the blood is to get through a cirrhotic liver. Interesting and very neat technology, very expensive, very expensive. And I'm not sure how many places in the West Coast actually do this with any regularity and any quality. And what I mean by quality is reproducibility. So let's kind of go back. We can talk about identification of risk factors for NASH, disease progression. Family history has a huge part in this. Not so much talk about some of the non-invasive markers. Some of them are better than others. And also some of it is also what you have available locally within the greater, and local, I'll say, within the greater Northern Nevada. So the role of liver biopsy. So risk stratification, we talked about that. No clear, yeah, this person should have liver biopsy except for the middle. And part of that is, remember that I'm going to be real cautious if I'm going to do a liver biopsy in a patient who has a spleen of 15 centimeters and a platelet count of 90,000. They have cirrhosis. You already know that. Do they really need a liver biopsy to help you decide that? Probably not. And the risk of bleeding is huge. The radiologists are good interventional people, can do a liver biopsy. If you're still very curious, they'll do a transjugular liver biopsy. So, and they'll actually pass a catheter through the jugular vein, down past the right heart into the hepatic vein, and do a through the hepatic vein biopsy into the liver. Piece of liver, you don't get as big a piece as you do percutaneously, but still adequate. But it's risky, and you really got to ask yourself, what kind of information am I going to get that's going to change my course of therapy? So the one in the middle is really where we're looking at to consider liver biopsy. How much of this abnormality I see is really related to cirrhosis? And I sometimes use this to motivate my patients to say, okay, here's your biopsy. You have stage 3 fibrosis. If you don't do anything, you're going to end up having stage 4, which is cirrhosis, all the complications of cirrhosis, liver transplantation to survive. So my focus is trying to determine, well, who of all the patients on the top really need to get the liver biopsy, and I'm really looking at this intermediate risk profile. I think these are patients that benefit most from a liver biopsy. Liver, again, way over to the right, risky, and I think you have a lot of non-invasive things that tell you the patient already has cirrhosis. All right, so again, we talked about, kind of went around this. Making diagnosis as surrogates are insufficient at this point. And we're starting to figure out the level of fibrosis staging. And again, we're looking for the 2s and 3s, not the 4s. We're already figured that out. And then the concomitant liver disease, we really ran through that. So non-invasive assessment of liver fibrosis, we talked about some of the arithmetic that's being contemplated. We're not there yet to make sure that we can rely on all these different markers. Right now, I look at this as more of a research tool, and maybe we can come back and in the future, maybe next year, talk about, okay, here's a new numeric study, or here's a new marker, and this is how you calculate this to know who's got what. What I mean by that is, if you understand the MELD score for liver transplantation, we're probably going to have something like that for fatty liver disease and who has NASH. Okay. So, well, I'm not going to read all this to you. This is pretty self-explanatory. Things to take home, how to differentiate fatty liver disease from NASH, important. Again, reliable exclusion of all the other concomitant things that can be involved in this. And then the whole idea of who should have a liver biopsy. Again, I'm not looking at my stage 4s, people that have cirrhosis. I really want to know who I need to intervene or push intervention at stage 2 and 3. So with that, I'll open up the questions. I purposely did not talk about treatment, part because that's a lecture in itself, and right now it is nebulous in the sense of there's no one clear-cut recommendation what to do for these patients from the medicine or drug standpoint. There is clear data that weight loss, the anti-obesity, treating metabolic syndrome is key in getting patients with non-alcoholic fatty liver disease who have NASH to turn it around and preserve their liver. So treating that is about the only thing that's out there. There's more to come. I have a big meeting again in May. This is a big topic to be discussed, and I understand that there are two medications out that have recently are going to get FDA approval for this. But again, it really pivots to not a medicine, but treating the whole patient and the whole metabolic syndrome. Otherwise, you're not going to get anywhere with these patients. Questions?
Any questions, cases?
So the understanding is that in the diabetes world, the only med that seems to have efficacy in reducing hepatic fat are the thiazolidine diet. Pioglitazone maybe has potential. It's always surprised me that metformin doesn't seem to be beneficial. Are you, as a gastroenterologist, putting patients on pioglitazone?
No, no. We really leave it back to the patients to manage their diabetes.
Okay.
What has been published in New England Journal of Medicine and has not been replicated, but I think the data is pretty solid, is use of vitamin E.
Mm-hmm.
And not megadose vitamin E, but standard 400 international units twice daily. That's about the only non-prescription thing, short of the weight loss and managing diabetes.
Yeah.
But again, more to come. It is a huge elephant out there. Really, I think liver transplantation, liver disease from NASH is really going to overwhelm a lot of us.
Yeah. Yeah, we thought it was going to be Hep C.
No.
Now that we can fix that.
Right. Again, it's an offshoot of the whole obesity issue.
Yeah. So are these slides, can we post?
Yes. The Northwestern said, sure, please, just don't publish.
Okay, it's a fabulous slide set. Oh my God, there's so much information. So we'll post that slide set on the website so that everybody has access.
Any other questions? Okay, thanks everybody. We have behavioral health tomorrow morning at 8. They're going to be covering benzodiazepines. Thanks.
Thank you.